Yeah, Mrs. Sanjana, maybe we can start. First, I would like to welcome, then we'll start. Okay?
Yes, sir.
Uh, Welcome to Dr. Madhuri. Of course, first of all, I would like to thank you for accepting our invitation to take part in this webinar. I welcome you. Over to Mrs. Sanjana.
Thank you, sir. I welcome one and all to the third session of today's webinar. We have with us today Dr. Madhuri Ghore, who is the resource person for the current session of the webinar. The topic that is going to be addressed in this session is communication techniques for children with hearing loss through auditory modality. Dr. Madhuri Ghore is currently serving as the Professor, Department of Hearing Studies at Dr. S.R. Chandrasekhar Institute of Speech and Hearing, Bangalore. She was the former principal and Deputy Director Technical at Dr. S.R. Chandrasekhar Institute of Speech and Hearing. Her areas of research include auditory evoked potentials, noise and hearing conservation, diagnostic audiology, and cochlear implants. She has guided over 58 dissertations. She has won several Best Paper awards at various platforms. She has served as the member, Board of Examiners or Board of Studies at various universities. She has been instrumental in completing several in-house and extramural projects. She has developed various test materials. She has published several book chapters. She has played a significant role in organizing several workshops and seminars. She has been working with cochlear implants since 1987, and she has a vast clinical experience spanning from 1982. With this brief note, I welcome Dr. Madhuri Ghore, ma'am. I request you to kindly take over the session, ma'am.
Thank you very much. Thank you, sir, for your warm welcome and giving me an opportunity here. So without much ado, I'll start the screen. I'll share the screen. So, good afternoon, everyone. And what I'm going to talk is communication techniques for children with hearing loss through the auditory modality. But first of all, I'd just like to tell that, I never believed it when Dr. Ratna used to talk to us about it. Though because none of the children we had seen were really, those, or at least those with significant hearing loss, were not doing so well by listening alone. So most of the time we were using oral, and that is also a limitation of those times because of the kind of hearing aids we had and the technological limitations. But the first time we saw that children could improve was after the 1990 ISHA-Con, when an auditory verbal therapist called Kathy, I don't remember her other name, came to Bangalore on Mrs. Kumadavali's invitation. And we saw those videos and we didn't believe, but she made a comment, because when she was showing when the videos were being screened, there are children with parents and children with hearing, children with hearing loss there. And there was some noise there, and then she looked at us and she said, I would have said that I heard that. You didn't, say anything. And that was one part. And in 1993, Dr. Daniel Ling came to our institute, and there we learned to really expect and even how to correct the speech. So historically, everyone knows Dr. Victor Urban's disc, Dr. Froschels and Dr. Max Goldstein, because those days there were no other therapists who decided that hearing was important and you had to give input through hearing. And later on in all our memories are Doreen Pollack, a speech pathologist, Siva Griffith, an audiologist, and Helen Beebe and Dr. Daniel Ling, who were educators. So they all worked on the auditory modality. And now we have our very own Dr. Jaspal Chaudhary, whom we all know, Ms. Aziza, Ms. Shefali Shah, Ms. Geeta Prasanna, and of course, we've seen the videos of Warren Easterbrooks and the others. So now, basically, for the auditory modality, we have two approaches. So one is the developmental and one is the remediation approach. So developmental approach such as AVT, which focuses on young children. But for older children, because many children are identified late, then you have the rings approach. So remediation can be done in school as well. Now, what is the base of the therapy? What basis has the auditory mode been used? So first of all, in children, you all know that there is brain plasticity and that neurons form synapses, and the younger they are, the better they grow. Now, why is that? That's because the sensory pathways, big synapse formation in the sensory pathways begins very soon, just before birth, and it's kind of at a peak around 3 months. And those linked to language, because it depends on the sensory input, they kind of peak around 9 months, and the higher cognitive functions continue. So one is linked to the other. And what happens if they are identified late? So here you can see on the left side that normal hearing, the auditory area is stimulated. And in the early implanted auditory area, some non-auditory areas, but those who are implanted late, these are only the non-auditory areas. So perhaps that is why, the progress varies so much. So, excuse me, early identification is really, really important. And we have to reduce the delay all the time at every step. So at the bottom of the slide, you can see the synapse formation and how the number of neurons are going to be the same, but number of synapses go on increasing and then they get proved. So now this reduced delay from the time the child is identified as having a hearing loss, please make sure that the parents talk near the child's ear. See, even at a regular speech, you might hear the speech at 60 dB SPL, conversational speech at around 3 feet. But right near the mouth, it's quite loud. And if you speak near the child, that 10 dB of, amplification which the ear gives is a lot. So speaking near the ear makes a big difference. And it gives power, empowers the parents, because everyone knows how to speak near the ear. Before I move on, I'd just like to share just remind and the UGs especially that you can see that how receptive skills develops from awareness to understanding connected speech. And here you're having a simultaneous attempting to use voice and using connected speech. So each step is kind of, running parallelly to the other. In language, so the development of language is very important, because language is the software by which you can plan, think, monitor, control impulses. As we understand more, the way we control ourselves varies, and we react to novel situations with non-habitual response. That is a big advantage that language has given us. So with the language development, you also have executive function, and so which all these are delayed, including how you think about the other person's understanding. That differs in children with hearing loss, because they did not develop the language, so they cannot imagine how others feel, or they cannot put themselves in the other shoe. And importance is that they should have the language too, because then only they can have a wide experience, even without actually experience by hearing. So this we all know: poor verbal language, unintelligible speech, and everything leads to poor academic performance and later to underutilized skills at work. So now, what happens if someone has been identified early and they have been worked up? Then they have found that many children who had this auditory verbal therapy, they caught up with the peers and they learned they were mainstreamed. Only thing is, there are very few studies in AVT, but it is more a thing. So, just 1 minute. All right, so now learning to listen and sorry. Okay. So now just everyone knows the link 6 sound test. Let me just remind everyone about the low frequency sounds and the high frequency sounds. And all the vowels you see are in the low frequency and all the consonants in the high frequencies. You know, even from your SMS language, that even if you use consonants, people can understand, but vowels alone are not enough to understand speech. Yeah. So now I just want you to, because learning to listen is so important, I want everyone to read this sentence. The possibilities that children who are deaf and hard of hearing to develop exceptional conversational abilities, literacy skills, and limitless confidence are incredible. Now, this, everyone is familiar with the sentence. Just want you to hear this. Now tell me how much you could identify. So just count the words. Now this is speech which is cut off at 500 hertz. So you have someone with hearing only up to 500 hertz. This is up to 1 kilohertz. Now you see when you can, the person can hear up to 2 kilohertz. Just. Yeah, so all of you would have noticed that when you knew the context, you could figure out a lot of the words. And that is how we develop from a closed set to an open set in children. So now suppose the link 6 sound test, you can see that low frequency, if each sound is gone up, gives information, excuse me, about a specific part on the spectrum. So the is the low frequency. If it is not audible with the hearing aid, then prosody is poor. And and all, they will, if that means they hear up to 1K and they are going to hear the manner cues. If they hear E, they have access to place cues. If they don't hear, they don't, and so on. So this part, everybody should just remember. So now we just move on to the auditory verbal main tenets. That is, children with hearing loss must have the opportunity to speak, to learn to speak and listen, become confident members. So in this, the main points are parents are partners. We are not looking down on them and directing them, do this, that. They are the partners. To facilitate speech and language, you should use scientifically the techniques, and we have to maximize audition. So maximizing audition is very, very important. And because it's a developmental approach, we are using natural developmental patterns of communication, stimulate cognition, and monitor, self-monitor, and review progress. So basically, In brief, it is that. So now this is a quote that children learn language best in playful, meaningful activities with someone who loves them. Now, obviously, infants, it is going to be the parents and the family. So in the therapy, we have 5 main domains that you're working on, and audition, language, speech, cognition, and parent guidance. So we just go through that in brief. So now everyone is familiar with auditory training. So all audition exercises, if you do with natural sounds, then carryover is better. So the purpose is each thing that you do in therapy should carry over in the real life. So um, you may start with the conditioned play response, but that leads to spontaneous alerting, and go on, verify, seeing if the child hears at 3, 6, 9 feet to prefer sounds, localization. And this is the discrimination, everyone knows. Now, to maximize audition, you have to have appropriate seating. So this is from Sound Steps. And that's Miss Shefali Shah, and that so you can see that the child is sitting in middle between the parent and the therapist, so that she can hear well, because their therapists are close enough to her. And this is a short video what parents sorry, this is not working, but okay, this is a video of how a mother can speak near the baby's ear, and baby will love it, along with the action. Like when the mother sings, she sways. So this, in the song also, it is the same thing. So now, even in identification, you have stages. So you might be working on supra-segmental. So typically you say, is this, what is mama angry? Or is mama sad? Or is mama happy? So the way you use that, the way the voice is used, they get the percept of the emotion. For older children, we might use pictures, angry, sad, and then the child listens and points out, differentiating between male and female, and varying the number of syllables. So varying the vowels, consonants. Now this part sounds a lot like the early speech perception test, right? And tests are also made to go in stages. So this is an early speech perception test, which was developed by Rashida and Yathiraj, 2004. You can see the first line are all monosyllables: dog, shoe, car. Next are bisyllables, and the third row is the multisyllables. So you can see that if the child shows, if you say dog and the child shows apple or umbrella, that means the child doesn't have the basic of temporal perception, and so that is how you will start. So tests are very important. I did not mention that you have to use the link 6 sound at the beginning of every session. But yes, everybody has to use at the beginning of every therapy session. Every time the hearing aid is switched on and off, the processor is switched on and off, the 6 sound test has to be done, so that sure if the child is hearing the full spectrum of sound. So then we come to comprehensions. Again, there are different levels. So responding to name, responding to music by swaying is a comprehension activities. Responding to common phrases, then it goes on to directions, get this and then that. Or after you, give water to mommy, just, put something else, put the book put back your books. So, and it goes on to listening in noise and describing sounds. So these are actually the steps and the goals, but you might be doing the activities through the session in different ways. And you can monitor and see what is. I hope this. Want all the hyperlinks. We'll go in the end at this, but you can just see on the sound therapy. See.
Ma'am, that will be playing on another window, ma'am.
Oh, okay.
So you have to share that screen onto this one.
Okay. All right. Okay, just hold on. Huh? Oh, I'm sorry about this.
Ma'am, you can minimize
I'll
this
just
PPT
go off.
screen.
I'll go off.
Okay.
Is it visible now again?
No, ma'am, you have to share it again, ma'am.
I have to share it again.
Yes.
Okay, now you are again. Now exit minimize. Okay, now I figured. All right. I think that is the problem. I can't share those.
Yes, ma'am. Now it is visible.
Yeah. Okay, I can't share those videos, but anyway, they can look up. So now you can just see that all this, now the same things you can use for language, for speech, for everything. And you can see that here we have awareness, discrimination to comprehension, then the meaningful input. And here this in each situation and you can respond. So in the beginning, it's a structured context that is like a therapy, then it's in daily routine, and then it becomes naturalistic. So each thing comes let's just come to the language. So now to develop language, first thing is joint attention. So you have to respond to the child's attempts to communicate. So if you want the vocalization to improve, you have to respond to the child. Child just shows hand like this or says and then immediately you have to respond to that. Maintain focus and then develop turn taking skills. We tend to be directive. Don't the child is putting some can be happening. Sometimes we want the child to respond. You can hold a mic and say, your turn. Or you can also, if there's a toy there, you can just prod it a bit so that child will say something. Is this sometimes the question arises, is showing the object, is it an action or not an action? So if you're using the big ball or the thing round and all, that is an action, I guess. But if you show the object with your finger, that is not, that is not like making signs or using, drawing away from the listening. So from there, you expect the child to listen to narration and associate learning to listen sounds. Learning to listen sounds are the first sounds that you might use. That is that, what does the car says? The car says beep beep, and what does the train say? Coo chuk chuk. So these are all the sounds which you might use, and to along with each object. So every time you use that to listen, you're facilitating. You don't call the train koo chuk chuk, but you say, where's the train that goes koo chuk chuk? Or you hide the train and you say, where is the, I hear this, I hear koo chuk chuk all the time. And then you search for the sound and then, there it comes. So that is really an audition exercise. And the same thing, it becomes also, when you use it consistently, it turns up into language. So child might say koo chuk chuk for the train, but then you say, yeah, that's the train which says koo chuk chuk. So you want a response to key words, and you expect also, how do you know the child is listening? When the child is sitting next to you and then you say, I see the train, I see the car, I see the bus. And you can see, because you kept the objects far away, you can see the child looking at them. Or you say, okay, give this to mommy, and child might give it to mommy. So you know that child is listening and child is understanding. So you can use songs. I don't know how this will work. There are action songs, like open, shut, and open, shut. I don't know if I dare try this again. I think we won't risk it. But you can look up the YouTube, see the songs. So you are going to use how you learn language. Use the audition first. That is, you've hidden the train, you've hidden the bus, and then made the sound. And you're using parallel talk, self-talk. So this is all regular speech and hearing SLP work. And these are what you have to listen. So always you say listen and make every time the sound is there, you say listen. And that's what Kathy was saying to us, that, you people are not responding. Someone coughs, you say, listen, I heard a cough. So you use the listen, you highlight listening every time you pay attention, and I heard that. And I can hear that, but I heard the alarm. I heard this. You can just move that. And then, so now for a number of comprehension and listening exercises, you can use a real set. Suppose you're packing a suitcase, you can say that, give me the shirts, give me all upper shirts or iron shirts, or give me the towels, or first give me the frocks. You can use it in a very natural way. So suppose you want to teach some, specific goals, then you can use a story. So in this, the story is that the cat is on the chair and a mouse comes under the table and tries to eat, and the cat goes behind the mouse. That's the story. It is to illustrate on and under. I'm sorry, it isn't playing. These are the kind of things you can use for listening and language. Or the kite is up the tree is a good listening exercise. Also can be used for sequencing. So your goals are not separate, as your goals might be separate, but you can use the same one activity for several goals. This is a picture description. And these kind of worksheets, even typically hearing children do, you can do it on under. Yeah. For speech, we have to start with the vocalization, and that's very, very important. The advantage of moment a child, and if the child is not vocalizing, it's good to check about the hearing instrument, and also see if the parents everyone is responding to the sound. Once the vocalization starts, then you increase the repertoire of vowel sounds, and by then the child will also start playing using different suprasegmentally segmentals, babble, everything. And this we expect. So in the common phrases, you make sure that you say, something fell ayo, or oh, or you can say that the mama said no, you change the intonation and get them to imitate. So in the cognition, you imitate facial information, then attend to story, recall. But let's come to this. See, parents have a huge task. Just imagine, we tell them, see, 3 years, they know 1,000 words, 2 years, they can 250 words, and they're going to go on learning. So that only makes the parents very scared. And we have to make sure that language learning is fun and part of general interaction. So these are all the situations in which interaction happens. And I'm sure, if we show the parents, there's a variety of language that can be used in all these situations. And get the parents, if they make an experience book, that's a lovely way. See, here the cow is being milked, and they pluck mangoes from a tree. This girl is plucking flowers, going down the slide. So all these things are a lovely way of talking about the past. If parents can't take photos, they can draw, that's fine. So since parents are partners, we have to talk to them about their progress, discuss the goals, and give feedback about the communication. So sometimes when you use a video, then you can show the parents that, you did this wrong, or this was what you did very well. That's why she responded. You can also show the parents that the child is progressing. You say, see, she doesn't hear, but when you said, I see the book, she looked at the book, you can see it in the video. Or she said that, where is this? Suppose you've hidden it and looking all around, pretending as if you didn't know. Where's the pencil? And then the child, kind of is pointing. You can see all that in the video. So you demonstrate the strategies to them so that you wait. Waiting is a very important thing. That someone you wait when you ask someone, okay, do you want this? Then you wait and hold it on, and then you say that. So suppose you ask, do you want more? Then you hold the juice and wait, and then look at the child, and child nods or gives some indication. Then you pour. So then only you show it to the parents. You showed it in the therapy, but also they might just show it from their videos. So the important thing is to review the progress every 3 months, and even during each therapy, check if the goals and all have been met. What is the cause? So now we'll just come to the remedial approach, and this was given by Dr. Ling and to the speech. So now in 64D, Carlos said no systematic efforts have been done, and there's no theory for speech, improving speech. So that's what Ling did. He said that informed, systematic, sustained effort is important, and he gave them how it has to be done. And he also said that teachers should be involved, not just the speech pathologist. So now he also addressed the link between speech perception and speech production. That is, if you hear a child speak, you can be sure that's what the child is hearing. So both you have to verify that. And he gave what is called as the phonetic level evaluation and phonologic. Phonologic is when they're all meaningful words, when the child says it effortfully. In the sense, they're always worried. They have to plan and think and say. But suppose you just say bibi, bapu, or something like that. Child, even though it may not say burr properly, but the voice and all might be better. When they're simply playing with friends, the voice and the kind of communication might be better. When they're running and playing, and then it comes up. So, yeah, this is just what he said. We don't know the variables. So, why is speech effortful? So he said that voice, the children with hearing impairment do not have independent control of voice, tongue patterns. And that's one thing which has been taught, and everything has been taught till it is more than accurate. It should be like automatic, and then it should be easy. So, and each stage has to be mastered. So he said that feedback loops are not enough. We have to, if it is overlearned, then the feed forward also develops. And so that pre-planning should be there. So that's when the speech becomes clearer. So repeated performance beyond accuracy. We all tend to stop at accuracy. Yeah, he said 16 out of 20 times accuracy. No, Ling says 90%, not 80%. And beyond the stage of accuracy. And yeah. So phonetic level, no conscious effort, then goes on to phonologic. So at the phonetic level, he vocalizes freely, there's suprasegmental and makes combination. And this becomes meaningful. He uses vocalization, calls mommy. A mommy is far away, he raises his voice, but he doesn't know otherwise how to manage. So this is a wonderful program given by Dr. Ling. So when he had come to Institute in 93, he kind of demonstrated some of the techniques to us. So this method we tried out on our children in 2002. We means my student Letina. So I'll just present a little bit. The ability, if you think that children with hearing loss can vocalize for 3 seconds continuously, actually it's not so easy. They sometimes say they don't vocalize continuously. So just check this out. I'll just show you the breath control. This is over 10 days, and out of 10 trials, you can see, we'll just see the vowel A because it varies according to the vowel. The blue line is the vowel A. And depending on the hearing loss and the thing, you can see that one child took about 10 days to get 10 on 10 correct. And as another child got it only up to 8, and this child has got it only up to 4 after 10 sessions. So it's not so easy to say that. So practice takes a long time. And this is about a 4.9-year-old male with severe loss. And all aided responses are within the speech spectrum except 4K. So you expect them to say, get a good voice and all. So spontaneous vocalization, you see, only 6 on 10 in a session. He got 6 times. I shouldn't say number of occurrences is only 6 in a 30-minute session. And vocalization on demand was easier. And he could sustain vocalization by the 6th day, and imitation of long and short on a different day. So you can see that these are the formants, and he was also able to say R-E. This is in the 5th day, and this is on the 10th day. So the vowel formants improved. So remedial teaching makes a difference in their speech, and clarity of speech is so important. In a recent post, they said that so many people don't like speech. It is correct, because if they learn to speak and no one understands them, then I don't see why they would like to continue to speak. They would prefer sign, and I think, if it would be natural. But if we work also on speech through hearing, or whatever hearing is there, and most of them do have hearing up to 1K, so fairly intelligible speech is a goal, but then we have to maximize hearing, do sustained effort in everything. There is a saying, if you want the pearl, you have to dive deep. I think we have to dive deep and be convinced that it can be done. Thank you.
Thank you very much, ma'am. It was a very enriching session. This presentation gave us a wonderful opportunity to recapitulate all the concepts related to auditory training, starting from the critical period, the brain plasticity, and various levels of auditory training and the hierarchy of auditory training. It was indeed a very informative talk, ma'am. Thank you very much.
Thank you. I'm sorry the videos didn't work.
Yes, ma'am.
So maybe I can just put up the links. People can take screenshots and see themselves.
Yeah, ma'am.
And my video also didn't work.
Just a moment, ma'am. I will take the picture.
We'll take a picture.
Taken, ma'am.
Yeah. This is for the action song.
Yes, ma'am.
This video, let me try playing it again. I don't know why it's not playing. Or maybe after Asha, ma'am. I don't know why this is not.
I have taken the
No, this
of the links.
is, yeah. This is my video, so
Yes,
it's not. I don't know. It's not. Maybe I can send it over for your students.
okay, ma'am. Thank you. That will be
I
wonderful.
can WhatsApp it. That's better, no? Because that's the only way now. I don't know how to manage this.
Yes, ma'am. If the participants have questions from their side, they can kindly post it in the Q&A section.
Sanjana, Dr. Ratna has raised his hand. I think he wanted.
Sir wants to speak.
Sir, please, sir. Your mic is enabled, sir. Ratna, sir.
Thank you. Well, I'm very happy with what Madhuri has said. There's a great deal to do with auditory training and audio-verbal therapy. But we should always remember, as Madhuri also brought it to a point, that there is a point at which the people will choose to sign instead of speak. But we should be able to encourage the children to do both, so that we don't sign at all. I mean, I used to say that for a long time ago, but I don't think so. I think we can use it as a bilingual approach, where they both speak and sign together. And that way, comprehension will be easier, faster for many children.
Yes, sir. I think they should be bilingual.
I agree with you. That's what I've been saying.
Yes, sir.
But they can do it. They can, because the whole idea is language communication is important. And if we want to achieve extra communication, then use a whole combination of factors, all factors.
Yeah, and many do feel left out from the hearing impaired. I mean, I've seen some people who speak very well also, but once they grow up, they wonder why they didn't learn sign. And they do learn,
Correct.
I think. They have
Correct.
they do become bilingual with
No, they
some,
should become bilingual. And I'm talking about simultaneous bilingualism. Sign and talk at the same time. So that one supports the other. When the two are complementary, they're not contradictory. So you're all right. If your sign and your speech are the same, are talking about the same things, communication is better, more comfortable. That's all I have to say.
Thank you, sir.
Thank you, sir. Sanjana,
Yes, sir.
Indra ma'am is asking for the
Links,
link.
yes, sir. We can share it to you, ma'am. Can we share it to you, ma'am? The links. Can we share it to you later, ma'am? Can we email it to you, Indira ma'am?
I think I need to
you can-
enable Indra
Oh,
ma'am's
ma'am can.
mic. Just a
No.
moment.
Yes, sir. Yes, sir.
There are questions. There are two questions.
Yes, sir. There are two questions, sir. Madhuri ma'am, can I read the questions out to them?
Yeah, sure.
Which is more effective, auditory verbal therapy or oral approach?
You know what? It depends on, see, if auditory verbal therapy is good when there is good hearing, it's the best. If you do oral approach, I don't know how to answer this in a straightforward manner. It depends on the child, and it depends on the commitment of the parents, and it depends on what is the quality of hearing. Okay, even if it's a
Yes,
oral approach.
Sorry, ma'am, I am interpret. I had mail and WhatsApp also, ma'am. Same this number. Indira, my name is.
Yes, madam.
Sorry, ma'am, you can continue, ma'am.
Continue, ma'am.
So suppose they have good hearing, I think, exploring hearing is a very, very important aspect. And half the time we don't, because we actually don't check what they are hearing. We may not verify with is the hearing aid appropriate. No, hearing aid, even if it is appropriate, what they can hear with the hearing aid, we may not always check. So that is very important. And at least if they are going to school and all, many schools, they don't, the hearing aid is on, but the battery is off. So oral, okay, I'm moving away from the point. See, oral is not, you can't say best or good, but if we improve the audition, then isn't it going to be an advantage for the child everywhere, because the child will get better quality of voice. So when the child cannot have access to certain parts of the speech, then you might have to use a oral, and then you come back to the oral. So how many words did you hear in the first part when you knew the sounds? Did you hear any words? Can I ask that? When you heard the filtered speech, were you able to get any words? No. The person who asked the question.
Is Hemalata, ma'am. But yeah, not many words could be
Not
heard.
many words, but if you didn't know the sentence, how many words?
It would have been difficult guessing.
So all I'm saying is you used like a close set, that you knew what was going to come, and that's when you could hear the words. Now, suppose you heard it many times, you would get more words. You won't get the whole, okay? But you might use the other cues to get some information. So that is, but if you did not have any audition, you wouldn't have, I mean, if you're not using your audition, you will just hear one da something. Correct. So whether you're using oral or only oral, they should hear. Now, if you remember this child also who had hearing up to 4K, if the hearing is not stimulated, hearing was up to 2K, but so difficult to, not this, sorry. Still not using voice spontaneously a lot, even in play. Okay, so in a 30-minute session, someone was counting how many times the voice was being used. So even in 30 minutes, the child used only 6 times by himself while playing a game or pulling something, some funny game. So if that is the case, then that means they're not paying attention to the sound, isn't it? So you have to work a lot on the listening part. And what can't be listened? It is oral. So it is not, I'm not saying hide your face all the time. I'm just saying that when you're working on listening, make sure it's not the face, it's the sound which is being heard. If you're using, okay, let's say in the auditory training session, no, everyone you bring the dog and it says the dog goes bow bow. You brought the dog and then you said that and say listen. But suppose you hide the dog in a bag and say, I heard you, you make the sound bow bow. And then you pretend, you ask Mama, what did you hear? And then you ask someone in the session, maybe another student, what did you hear? Then you say, I heard bow bow. And you look around, child also is wondering what is happening. But in the meantime, child has heard that bow bow so many times. And then you bring out the dog from wherever you've hidden it, from the bag or under the table, and bring it out and then show the dog. Then the audition effect is longer. But if you don't highlight that, then child will not be able to link it to that. So if you don't highlight, you don't learn.
Thank you, ma'am. Thank you for answering that question. We have another question posted, ma'am. They have asked, what is the role of school teachers in auditory verbal therapy?
Can I ask which school teachers? Can they give that answer?
If the person can retype the question and particularly say which school teacher, I think we can take up that.
Because auditory verbal therapy is for young children, all below 3. So,
okay, meanwhile, they give the information. Can we take up another question we have? What may be the problems usually faced by children with hearing impairment in an integrated school setting?
their integrated school, there might be 2 kinds. Like I have seen 2 kinds. That is one in Bangalore, where there might be 5-6 children with hearing loss in one class. And in some other schools, there's only 1 child with one in the class. So I'm sure the children may not hear. Just a minute.
Yes, ma'am.
So the children, I'm sure they do feel left out and they do get, but I've seen when the children, there are many children with hearing impairment in one class, they tend to stick to each other, not with the regular children. And it's also not easy to mix. I know one of my friends had a hearing impaired child, and she said, we don't understand her speech at all. So they tend to make them leave. So they need to have some good speech, and teachers should know and make sure that they're integrated. But if it's a single child and if the school is good, They do well.
Excuse me, ma'am.
Yeah, tell me.
Yeah, ma'am. Thank you, ma'am, for answering that question. This is in continuation with the previous question, wherein they have specified the type of school teacher. So they have said that it is the integrated school teacher's role, which comes into play with respect to auditory verbal therapy, ma'am.
I think, can I answer that after some time?
Yes, ma'am. Can we take up 2 more questions that we have, ma'am?
Sanjana, I think madam is not here.
Yeah.
Probably because of which she will answer it later.
Yes.
Sanjana,
Yes, sir.
Question. When Madhuri can come back and answer the next question.
Yes.
I think it's okay. We can even mail Madhuri ma'am and
To her?
You can mail the questions back to
yeah,
we can get the
should be
answers.
okay.
Yes.
thank you, Dr. Madhuri. It was very informative, very useful. And I once again thank you for sparing your time and making all the effort in spite of your busy schedule and taking part in this webinar. Thank you very much.
Thank you, sir.
Thank you.
Sir, can we begin with the next session, sir?
I'll stop sharing.
I welcome Dr. Asha. Waiting for your next presentation. Thank you for taking part in the webinar. I welcome you. Over to Mrs. Sanjana.
Yes. So I welcome you all to the 4th session of today's webinar. We have with us Dr. Asha Yathiraj, who will be addressing the topic Communication Techniques for Adolescents and Adults with Hearing Loss through Auditory Modality. Before we begin, I would like to take this opportunity to introduce Dr. Asha Yathiraj to all of you. Professor Asha Yathiraj is currently working as the Professor of Audiology at JSS Institute of Speech and Hearing. Dr. Asha Yathiraj is an alumnus of the All India Institute of Speech and Hearing. She is an academician, researcher, and clinician holding a PhD in Speech and Hearing from the University of Mysore. She has also received training on oral rehabilitation and auditory processing disorders as a WHO Fellow at the Central Institute for the Deaf, St. Louis, USA. She has a teaching experience of more than 30 years and has taught undergraduate, graduates, and doctoral students. Her research experience spans 40 years. She has approximately 150 scientific publications, which includes publications in leading international and national journals. She has also written several chapters in books. She has received many national and international awards for her scientific work. Besides receiving the prestigious Professor Padma Shri S. Kameshwaran Oration Award in 2007 for her contribution in the area of audiology, 12 of her scientific presentations have received the Best Paper Awards in several national conferences. She has developed several tests in the areas of central auditory processing and speech perception. She has also developed therapy materials for the management of persons with hearing impairment and those with central auditory processing disorders. Additionally, she has undergone training for cochlear implantation in Australia and has considerable experience with the same. She is an active member of several professional associations. She has served as the president of Indian Speech and Hearing Association, and she was also the president of the Mysuru chapter of the association. With this note, I welcome you, ma'am, to the webinar and I kindly request you to take over this session.
Thank you, Sanjana. It's a pleasure to deliver a talk on communication techniques for adolescents and adults with hearing loss through the auditory modality. Before I start my talk, I really would like to thank Dr. Nataraj for giving me this opportunity to talk in this landmark webinar series that is marking the 20th anniversary of JSS-ish. Although I am a part of JSS-ish, I would like to congratulate all the staff, especially Dr. Nataraj, who have brought this institute to its current status. Before I start again, I would like to say how all the other talkers in this set of webinars series have said that they have chosen topics that they have worked extensively on and talked about what they have contributed over there. I have chosen a topic that I have not worked too much on. And the reason why I have chosen it is because there's quite a bit of there are not many people who have worked in this area, and my slides are not moving. Yeah, and they not work too much in this particular area. The focus has always been on children. When you talk about anybody with hearing impairment, right from the time I was a student, and it is there in the coursework. But our tendency is always to focus on children because we know that they are the ones who have major part of problems in communication. So we tend to work more with them rather than the adults. But we need to remember that auditory isolation creates problems not only for children, it also affects communication in adults. And besides communication, it also affects their social, leads to social isolation, cognitive decline, psychological problems, affects learning, because this is especially in adolescents and young adults. And we're not talking about those who have congenital hearing loss and have become adolescents or adults. I'm talking about even those who have got acquired hearing loss. They also continue to have problems because of their hearing impairment. And of course, the people who are going to be having problems in their employment, and there's high likelihood that they will lose their job because of this problem. So even though adults with listening difficulties may have communication problems, we don't tend to tell them to come for any kind of therapy. We don't think of doing anything for them. And there is some problem in trying to advance my slides. Okay. Especially in India, we would find that hardly anybody is working with adults, trying to give them communication training, and it's not given much importance. And it's given some importance for those with cochlear implants. But for those who use hearing aids, we hardly work on them, and we don't even recommend anything for them. So one, it is the clients who are very reluctant to go through this, any form of therapy. One of the reasons that they would tell you is because they have problems in commuting for therapy, or they are not motivated at all. So they just say, okay, let me go back home. Let me try at home, and I will see whether I can somehow manage to communicate. So they're not motivated to come in for the sessions there. And also they don't have adequate support from their home for where people will bring them. If they have a major problem, yes, somebody would bring them. But when it looks like that the problem is not very severe, and they say, okay, you're hearing well enough, that's enough. But a lot of our patients who wear on hearing aids, they are hearing, no doubt. But with some additional training, they're bound to do much better. And as I go through my talk, I hope I will be able to convey that information. And one big problem in India is that we as professionals don't actually recommend communication form of training for most of our adults who come to us. And we find that they have difficulties in communication, yet we don't tell them come in for therapy. So we find it difficult to motivate them. We might try, and a few of us who do recommend it will just give an option, say, why don't you try and come? And the person says, I'm not able to do it. And we just say, okay, we let it go. The major reason that I find that people don't make this recommendation is because they don't know what to do. So if you knew what to do, you would be able to give suggestions about communication techniques and training over there. So this is the set of methods that I'm going to be talking about. And besides this, there would be other aspects also that I'm going to be talking about. But the major one that I'm going to be focusing on is speech tracking. So it's a very simple technique. It's something that you should be working on for even older children. Madhuri just made it clear, saying somebody asked this question about ABT, and I said, and she mentioned over there saying school teachers don't work on ABT. ABT and all of the techniques that she talked about, meant more for children who, before they go to school. So once they go to school, yes, you might be giving some kind of auditory training kind of activities, which could be also used for adults, which I will talk about very briefly later on. But the older children, so almost from 8 years, when I've given the topic saying it is for adolescents and adults, but I have started using these kinds of techniques even for children as young as 8 years. So they've got the language. So I'm not talking about those who don't get information through the auditory modality. I'm not talking about those who require sign language or require any other form of communication, but it could be speech reading along with audition. So here I'm only talking about people who get some benefit from listening and also some benefit through speech reading. So if they're not getting that, definitely what Dr. Ratna talked about, you would definitely want to be using a bilingual system where you're going to be teaching sign language also. So if the person is, even if it's an adult, and you find that the person is not getting good enough auditory cues, that is, their speech identification scores are poor or their speech is out of the speech spectrum, then you don't recommend any of the techniques that I'm talking about here. So this is only what I'm talking about is targeted for those who are getting benefit through the auditory modality or some benefit through the auditory modality. So let's start off with speech tracking. And originally, the speech tracking technique was meant to be done as an open set task. And it was given by DiFilippo and Scott, and it's pretty old. And since then, it has been modified over the years. And when DiFilippo and Scott gave it originally, they actually gave the technique for evaluating speech reading. It was a test. And then later on, people just modified the technique over there and said, it is a wonderful technique also to give therapy. So it moved on from being a test to being a therapy technique. And you can use it still as a test, or you can use it as a therapy technique. So you could be doing it with speech reading, you could be doing it through auditory modality, or you could be using a combination of both. It doesn't matter, it depends on the person's ability. So here I am talking about communication. We're not talking about only the auditory modality. You could be talking about any of these modes. So either it could be visual. When I'm saying visual, I'm not talking about speech reading. I'm not talking about sign language. I'm talking about speech reading at this point of time. So the technique involves where the person has to repeat verbatim what is read by a clinician. So you choose material which is age appropriate. So if it's a child who's 8 years old, I would use material that is more age appropriate from her school book or a storybook that is that age. So that's the beauty of this technique. You are not stuck with any one material. You can choose whatever is appropriate for that particular age group, and you can use it. And then you're going to be calculating something called word per minute score. So it doesn't matter whether it is being used as a test or you're using it for therapy. This word per minute score is something that you're going to be calculating. So I just picked up something from day before start of Mysore, put up over here to give you an idea about how you could be using this material. And the reason you're going to be seeing this yellow highlighted content over there is I have actually blocked it in words of 10. So when I have to calculate the number of words over there, I'm just counting the blocks. So that's just from ease of counting the word per minute. So it's nothing to do with the way you would be actually reading out the content. You read the content out as a therapist naturally, using the pauses that are appropriate for that person at the correct places. So don't pause at the end of each of those blocks. Typically, when I'm using, I mean, here I have put it up with the highlighted mode over there, but when I'm using a book with children or with an adult, I have with a pencil, I just mark out blocks of 10. And this is only for ease of calculation. So what you do is you read out the content over there, and the person has to verbatim repeat the content. And when I say verbatim, it is word to word. So if they can't get a word, you have to do something to make sure that they're able to repeat the word. And I'm going to be talking about another technique little later on called communication strategies. And lots of people have given it, and including myself, where I have tried to make it appropriate for Indian situations with one of my students. And I'll talk about that. So technically, speech tracking should be used along with this communication strategies, and then it works out wonderfully. So the person asks for uses different strategies to be able to repeat the words as fast as possible. So your aim is to try and get the person to repeat as many words as possible. So over the years, I've adapted the speech tracking technique that was there, and I found that a lot of my patients were not able to do it the original way, that is just with the auditory mode. And I have not worked too much with the speech reading part of it. My initial days before better devices came in over here, I'm talking about, when I say initial days, I'm talking about the 90s. Okay, that's the point of time when the country moved into much better devices. It opened up a lot of avenues for those with hearing impairment. And so a lot of our clients moved away from having to be using speech reading to be able to use their auditory modality primarily for communication. So I'm talking about those individuals, but in spite of having good devices, some of them didn't have good speech identification scores. And so I came up with this set of change of, making it progressive, moving from a very easy task to a more difficult task. So I've just called them different levels, and I've actually categorized it into 5 different levels. And it works wonderfully, and I have tried it out and it works beautifully. So you choose a simple passage typically when something that is very familiar, and even if it's an adult, you choose something that is familiar. So some current topic. So like the way I picked up that earlier passage, it was about migrants coming back and about transportation and everything about the COVID situation. Everybody's talking about it. So that's the reason I picked up that, saying it's a current kind of a topic over there. So you don't take a very long passage. You take a relatively short passage and you read it out, and it should not, that passage should get over in about 5 to 10 minutes. That's the time period that you want the passage to get over with. So choose a passage that is appropriate. And in the initial stages, what I recommend is that you take the written material. So like now I picked up that thing from Star of My Soul, I would have actually given it to the patient. So the patient has also got, or the client has also got the written content over there. And I, as a therapist, would be reading out this verbatim. And so I normally would be giving a pencil. Let me pick it up. And then I ask them to, with the back of it, it's not that they're going to be writing on the book. So they word to word, they continue to just point out to the content that is going to be there, that is written over there. So that's a very easy task, and they just follow what is there. And actually, half the time, the person is just guessing over there, but the intonation and the way you pause and everything, they know. So at that point of time, actually, the person is just getting content about saying, okay, the person paused here, then I need to pause here. So it's just signal on, signal off, that kind of information that they're getting. And you calculate the word per minute score again in the end of it. So the person doesn't have to be using communication strategies over here, because it's very simple and they're just continuing to point. So now the second level, where it's again a closed set task. And again, you're going to be giving this written material, but instead of going in the order in which you have the material is written, you randomly pick up sentences from that passage and read out. So now you're going to get the person to be actually listening a little better and picking out which is the passage that was being, or which of the sentences that was being read out. So you again, you always start from a similar familiar passage and then gradually proceed to an unfamiliar passage. You could be using level 2 itself, doing all of that. And remember, you calculate again word per minute score. And the reasons, remember, I put that block over there. If you have those blocks right away, you can calculate it and tell the person. Otherwise, in the session, you're sitting, wasting time sitting, counting how many words they actually did. And that's the reason, they were able to repeat. And that's the reason I recommend that you use that block. So you mark out saying sets of 10 words. Now, level 3, you move into an open set task. And here now you're doing this entire speech tracking again, but without the written passage, but the person knows the topic. So you tell the person saying, I'm going to be talking about, let's say, COVID, the very broad topic at this point of time. Okay, let's move it into more narrow thing, vaccination. So I'm talking about an older person over here. I'm not talking about like an 8-year-old at this point of time. When I talk about a vaccination, maybe I'm talking about a 20-year-old or plus, 18 plus, that kind of an age group who will know about it. So they know about vaccination and those are the issues that are being talked about. And then you read about that. So some topic that is not controversial. So don't bring up anything which will agitate the group over there or the person that you're doing it. So again, at every time I tell you, calculate the word per minute score. Then you go on to the level 4, which is again an open set task. This time again without written material and without the topic being told. So you are now making the task a little more difficult. So you don't tell the person what the topic is and you just start off. But if you find at any time that the person is finding the task too difficult, go back to your earlier levels. There's nothing that tells you always have to progress upwards. You could always go back to the earlier level and you keep it in your mind. You don't have to tell the patient or the client that this is what I'm doing, I'm going back. Oh, you couldn't do this. All that negative kind of feedback is not something that you want to be doing. Doesn't matter what the age of the person is, you always want to be giving some kind of a positive feedback. The end of the session, the person should go feeling happy, saying, I could make some progress. That's when they will want to come back for more sessions. If you send the person away unhappy, saying he couldn't make progress in the session, he and his communication partner are going to be very frustrated. They go back home, they're feeling unhappy. And so they are going to be having a bad day over there because they didn't make progress. Always make sure you just go back a tad easier, make the task a little more easy, and then let them go through. So then the last of the sessions at the levels that I'm going to be talking about is going to be without the written material, without the topic. But the big difference here is that you're going to be having shift in topics. So you're going to be shifting the topic over there, and that is really difficult. When you keep shifting topics from one to the other, individuals find that extremely difficult. So if again now they find it difficult, go ahead, go back to the earlier level where you write saying, I'm going to be shifting topic 1, topic 2, topic 3. So I'm going to be talking about transportation. I'm going to be talking about COVID. I'm going to be talking about vaccination. So 3 related kind of topics at this point of time, but they are all shifting topics over there. So that's what you would do. And everywhere you are going to be talking about calculating the word per minute score. I'm going to be telling you now about communication strategies. This is what you use hand and glove along with speech tracking. So the way I actually do it is, though I talked about speech tracking first, when I work with the patient, I first start off with communication strategy. So I don't start with speech tracking. I first try and teach them about communication strategies. And it's something that is going to be used to prevent a communication breakdown. So I'm going to be talking about a lot about communication breakdowns over there. So you have a communication partner. So who you start off talking with, it could be with the clinician doing it with the client, or it could be the spouse doing it along with the client. So it doesn't matter who it is. I would always advise saying, you do it once or twice and then let the communication partner, the actual communication partner who's going to be at home, take over. So that's the way it should go. And remember, there are two different ways or two categories of communication strategies: anticipatory and repair. And before you start off these telling them about the anticipatory and repair strategies, it is necessary that you let the speaker know about the strategies. So the kind of strategies a person may have to use may vary from one situation to the other. And typically when I start off using the communication strategies, I don't expect them to memorize them. You encourage them to memorize them. But I normally would write it in tiny little note cards and put it on the table over there. And so then the person looks at that and is able to make a decision saying, okay, this is the one I should use. So what I tend to do is also I put it in a hierarchy. The kind of strategies that I want them to use, I put that on the top. So, and you can vary this. It depends on the client's requirements. So somebody might want to be repeating, and I will talk about these strategies in a little while. So some of them maybe you want them to be encouraging the person to just say, repeat one part of it. You don't want them to repeat the entire sentence. Remember, if they say repeat, you will repeat the entire sentence. It's going to take so much more time to communicate. But if they say repeat only the first part of it or repeat the second part of it, so then the entire communication is going to be faster. And obviously the word per minute score is going to become much higher over there. So you encourage the person to use anticipatory strategies as well as the repair strategies. But first, you always encourage them to use the anticipatory strategies. That is before the communication starts. So this is the set of strategies that actually it's not exactly how it is given. This is a project that I did along with Manoj. Manoj was my student and quite old, but it's something that still plays and is still adequate and you could use it. It's not written in this format in the actual project. It's given in a lot more detail. And actually I take it out as a handout and I give it to the patient and I say, this is what you can do over there. Here, I've just given it in abbreviated form over there. And I'm not going to go into details over there. It'll take up too much of time. But all of these are strategies that you take before the communication actually takes place. So you make sure that the lighting is adequate. If you are somebody who needs to be speech reading a lot, even a person who's hearing actually likes to see the person, because why do I want to switch on my video over here? It's just that you like to watch the person who's talking over there and you're looking at the facial expressions, you're looking at so many things. I don't know whether the image is clear or not, but you like looking at the person who is talking over there. And you need to be talking naturally. Nothing is going to be unnaturally talked over there. And so you, as far as possible, talk in a very natural mode. And then the person himself or herself could take away these any kind of disturbance that is there. So just before I started, I actually at time texted to somebody saying, I'm hearing a disturbance and I didn't want that disturbance while I was talking. So if there is disturbance when I'm talking also, I would expect you all to tell me so that you can say, I'm finding it difficult to hear and I need you to make some change. So again, repair strategies. These are strategies that you use after the conversation takes place. So, or while the conversation is underway. So I've just put in a few of them. I've not put in all of the strategies, but these are just of the examples that are there. So I'm just going to be specifying a few of them. You may ask the person to rephrase. These are the kind of things that a person typically will not do. Let's say now somebody has difficulty hearing the higher frequency sounds. And I say, use words that are more in the higher frequency region. then I could be rephrasing it so that I try and get a low frequency set of words over there. So which vehicle did you come in? Vehicle is not such a common word, maybe. It is a frequently used word, but more commonly would we say, did you come here by bus or by car? And I will talk about other techniques also where you can use different ways of asking questions over there. So you could, this is something that I think I would really like a person to use. Listen, the listener repeats the message to confirm what was heard. And I really like this kind of strategy. And I use it with children, I use it with adults also. So for instance, like I would have told the person, say the train arrives here at 5:30 p.m. And the person who's listening now would repeat back, the train arrives at, and so they confirm to me saying that they've heard the beginning part of it. And I only have to repeat the last part of it. So this is now asking for a confirmation over there saying, this is the part that I want. Or the person could be saying 5:30 and then say AM instead of PM and then that again. So things like timing of something, saying the webinar starts at this time and the person doesn't hear that, you could then also resort to giving it in writing. So some things are very important, and it doesn't matter whether we have hearing impairment or we don't have hearing impairment. You would say, okay, please write it and give, because this is an important information. So use communication strategies along with speech tracking, and that makes the communication breakdowns much lesser. It makes the ease of communication so much better. So now let's see. And there's lots of literature that goes about talking about saying how communication strategies do work, and definitely it works. But I'm just going to talk about, again, one of my own studies that was done some years back. And this was on a very small group of adults. And let me tell you, even though it was 9, it was with a lot of difficulty. Sarah Thomas managed to get this set of 9 adults. It was just people with moderate to moderately severe hearing loss. They were not willing to be a part of the study at all. And we had a lot of encouragement to motivate them to get them to be a part of the study. And as a part of the study also, we wanted the communication partner to be a part of it. So it was not just the person with the hearing impairment who was not willing to be a part of the study. It was also the communication partner. Sometimes the communication partners were willing, and both ways. Either one of them were not willing to be a part of the study. So all of them wore hearing aids. And it was just 5 sessions that they had to undergo, and that's all that they were willing to give time over there. And so what Sarah did was she was actually taught the people communication strategies, the same set that was developed by Manoj and me. That was the set of communication strategies she actually taught them. And she made a list of them, and we had this hierarchy of ways in which they could use these communication strategies. We did not prevent them from speech reading. It was not only about listening through the auditory mode. It was just about communication. And normally also you watch a person when they talk, right? So that is all that we were looking at. If they wanted to speech read more, we'd let them speech read more. If they wanted to hear more, then we let them hear more. It didn't matter as long as they were able to repeat everything verbatim. And so we were measuring their performance using speech tracking. So what we did was, before the therapy, we measured speech tracking word per minute score, and after the therapy, again, after this just 5 sessions, we measured them again. So to make a comparison with the same passage, we administered around 20 adults who were having normal hearing, and they were age matched with the group over there. So it obviously, with more adults, it was like for every age group that we took in the group with hearing impairment, there were 2 or more, a little more than 2 who had normal hearing. And look at the scores. The normal hearing individuals had 83 word per minute score for that set of passages that we had, whereas those with the hearing impairment, even after training, they got a score which was lesser than that of the normal hearing individuals. So the point that I'm trying to tell you is that even with just 5 sessions of training, there was a significant improvement in the communication of the person, the word per minute scores, or the ability to use their communication strategies and communicate much more effectively when they were given this training for communication strategies. But the normal hearing individuals continue to be significantly better than those with the hearing impairment, even after the training. So my suggestion would be probably 5 sessions are not adequate. We need to be giving more number of sessions to try and make them do better. And there's definitely a need, we didn't measure in this one maintenance. So there's bound to be a decline in their abilities over a period of time, unless, of course, you continue to use the communication strategies. So now I'm going to be moving on to how to select the topics. So I told you that you could be doing speech tracking using topics over there, and but there are ways in which you can pick up the topic. So Erber has, I'm a big fan of Erber. Okay, so you're going to be seeing me talk a lot about Erber. And Erber, I have his beautiful book. I'm going to be showing you this book. This is my Bible for adults. It's a beautiful book. And this was the older version that I have. And that's out of print. And then 96, there's another version. He's come up with the next version of it. It's a brilliant set of books, and I would really recommend that every one of your libraries should have these books by Erber, and he's brilliant in his ideas over there. So he's given very catchy titles for all of his techniques. He's called it Topicon. So it's a simple conversation sampling evaluation practice procedure. So a way to get list of topics. That's how the whole thing is. And so you select the topics in a very systematic way. So you don't just randomly pick up a topic when you start off. Remember, I said start with a familiar topic and then go to a more unfamiliar topic. So he has come up with a technique about how to go about these topics. So you make the client list a set of topics that he or she likes, and the communication partner would also list out a set of topics. Then you as a clinician could also list out a set of topics. So then you choose from these ones that both the communication partners and that is the spouse and maybe the client over there, both of them list a particular topic as being of interest. So let's say a TV serial. So both of them like watching a particular TV serial. And so that would be a familiar topic to both of them. And so you would start off with that topic. Then you would choose a topic maybe which is more of interest to the client and not so much with the spouse. So you choose one that is with the client, and this makes it a little more difficult because the spouse who's going to be reading about it or asking questions about it may not find it as easy to ask these questions. And so the questions are not the typical kind of questions that you ask about. So let's say Wimbledon, you pick up the topic Wimbledon, and let's say the spouse doesn't know too much about Wimbledon, whereas now the client knows about it. And so the kind of questions that are going to be asked are not the typical kind. What is Wimbledon? And then that person is going to be saying, this is not a typical kind of question at all to be asked. Okay, so then you can choose an uncommon topic. So the clinician would now choose a topic which neither of the communication partners have chosen. That is the client as well as the spouse has not chosen it, but you as a clinician have chosen it. So now it is something that is totally unfamiliar. And it is again the communication partner that you would request to read out the content, but you as a clinician could also be reading out. So then again, you can talk about a topic that is really unfamiliar. So let's just randomly pick up some topic that is totally unfamiliar to both of them, but it should be age appropriate. Okay, so let's say somebody is a graduate or somebody who's has finished his master's level over there, and then you say, okay, let's talk about plagiarism, and a topic that most people don't talk about, but you're picking up a topic, and that's really difficult over there. So these are ways in which you can be choosing your topic. Now, Erber again has given another set of questions. So that was just picking up your topics over there. And then you have a set of questions. And so a lot of times when you as a clinician are trying to talk to a stranger over there, it's very hard to have this communication going through. And especially if you're younger than the client over there, you find that extremely difficult. I remember one of my first clients, the adult clients, I think he was a professor, and he was a professor who had retired professor and he had worked in cancer. And I was trying to do this entire technique with him, and I was pretty junior over there, and I found it really hard. And I was very intimidated trying to talk to a person who's so very senior over there and having a conversation with the person. So that's when this kind of a technique, Questar, which is again given by Ober, he's got a set of 30 questions, and I'm going to be putting up these questions over there shortly. So these, and they're all interrelated questions. So this is something that you could start off your therapy instead of going on to the topic on and having an open set, depending on the person's abilities. Of course, if you want to go down a step, then you can say, okay, let me use this technique over there. And there are he says there are about 48 different topic possibilities over there, but you can have as many as you want over there. And the client asks the questions about the places that the person is supposed to have visited. So the client asks the question, and then the client is given an opportunity to listen to the questions. And then, so the clinician might use communication strategies. And here now are the questions that are there in Questar. And I told you there are 30, and that you're going to be seeing 31 questions over there. So I added one over there. That was my own experiencing. I found that a little strange starting off about a particular topic. So if you want, you could just give the topic to the person, and let's say I gave go. So the person is already saying Coog is the place to, and when did you go? These are questions that are, who's going to be asking initially? It is going to be the person with the hearing impairment who's asking the question. So you give this list of questions there, and you are going to be answering it. So this is quite a difficult situation because the person doesn't know what are the things that you're going to be talking about. So I have initially said, okay, you could use, can you hear me? It says my internet is not stable.
We can hear you, ma'am.
Okay, I assume it's clear?
Yes, ma'am.
Yeah, okay. So yeah, so you continue with this thing, and if the person finds it very difficult, you can shift. So you ask the questions, and so they know the questions and they're familiar with the questions, and but you can start off with you asking the questions. And so if you want, you can do it the other way around also. And again, Uber, and he's given us ways in which you can progress to the kind of questions. So the questions that I just showed over there were open set questions. But sometimes the person might find it very difficult over there. So you could start off with yes, no questions. So if you could be from the same scenarios where you talk about Coog. Did you go to Coog or did you go to Mysore? So you're giving them a choice. Did you go to Coog? Yes, no. So I have given different other examples over here. So you have yes, no questions, and you progress to choice-based questions where I said, did you go to Coog or did you go to Mysore? Then you have specific questions. Specific questions, when he meant it, it is about something that is very specific to the person. What color dress are you wearing? How many coins do you have in your pocket? So it's something that is very close set for the person, and he knows what you're talking about. So the general questions would be something that is not present there, and you're talking about something that is not in the situation. So there's no situational cues. And then you're asking questions. So, and some general statements also, or always, even with children, you always progress from question-based to a communication where you just make statements. So let's take this example that I've written here. This chair is not very comfortable. So I make that statement, and I expect the client to now come up with another statement over there. Said, shall I bring you another chair? So that was a question he asked. Yeah, it is really old. The wood is all worn out. The cushion is worn out. So both are statements. So many ways that you can have, and that's the target that you want to always get in. The communication goes back and forth. It's not always questions. You always have a communication where you make a statement, the other person also makes a statement. Okay, so I'm now going to be talking about a technique, and those were pretty old techniques, and I tried very hard to search for newer techniques. I put the link in the bottom over there, and this is available on the net. And this is something that has been prepared in Australia. And I thought it was a brilliant set of material over there. It's based on a lot of literature and a lot of research that has gone in, that they came up with this technique over there. So you see there are 6 modules that they have listed about over there. And you see the modules are going from an easy task towards a more difficult task, listening to public address system. So it's going from an easy task, going to background noise, to conversation around the house. So that means in different places, the person is not necessarily in the same room. That's what they mean over there. Communication with a difficult speaker. So I am told to be quite difficult because you can't speech read me. And but hopefully I'm talking clear enough at this point of time, but I don't always talk clearly when I'm talking to my communication partner at home. So that's my husband. So he always tells me, oh, you're not clear over there, because I don't make the effort to talk clear enough. That's what that's a communication way of talking. This is my talk at a lecture, and I don't always talk so clearly. Then listening in other signals, that is like with TV or the telephone, those are kinds of techniques that you would also use, a public address system. So with this current scenario, you could add on about listening through the web, like these techniques over there. And for each of these modules, they've got sets of handouts. So it's all in this beautiful material that is available online. I recommend that you go through it. And it starts off with saying, what does the adult actually think that his problems are about? What are his problems? So you understand his problems and then work on from there. So he has to write out saying what is his problems. So the communication partner also writes out what are the problems they face. And so you can, so these set of modules, I mean, handouts that I've written here, actually more of them are used just for module 1. Like this, there are 30 of them. And there's a lot of literature that they have actually published about this technique. And they have proven using a double-blind approach that the technique actually makes about a lot of improvement in different other ways. So they've run tests on the individuals before and after they've used the technique, and the person has not known whether they've gone through this module or not gone through this module. The person who's running the tests, that is, they don't know what kind of technique the person actually went through for training, and then they are going to be giving the content about how it is for the progress. And so they've proven that it is a good technique. So that's about this technique, the active communication education technique. And I thought it was brilliant, and it's available online. I suggest you go use it. The communication partner is the most important person over there. And I think Jayashree Bhatt, when she talked about her technique, when she gave in a webinar, she also made this comment. And it doesn't matter what the technique is, whether you're working with children, you're working with adults, or you're working with any kind of disorder, the family is the most important person over here. And here I'm talking about the communication partner. So they are extremely important individuals if you want communication to take place adequately. So they should sincerely want the person to communicate. So you don't choose a person who comes in over there saying, I've come there because I was forced to come in over there. So I'm going to be talking about this one lady who came in. She was a teacher. And then I said, you have to bring in somebody with you, because I cannot give you training with you coming alone. There has to be the communication partner so that they can take over at home also. So the person actually came with her teenager daughter. And I said, why didn't your spouse come in? So the spouse was not willing to come in, and I understand he was working. So then she brought in the teenager daughter, who sat there with this bold expression, says, "You are." It was right from the beginning. I could see she was not motivated. So you don't want somebody like that, and that's what happened. That lady came for 2 sessions, and that was the end of it. So I have hardly had enough of experience, because most often they are not motivated, not because they are not motivated themselves to come. The communication partner is not motivated to bring them for the training. So the person should be also able to hold the interest. Obviously, this teenager daughter was not able to hold the interest also of the adult with hearing loss. And this is a very important point, the third one, where you say turn taking. You as a communication partner should be able to make sure that you take over the conversation at times, because typically what a person with hearing impairment will do is they take over the conversation and they will talk. It's like a monologue. It's exactly like what I'm doing now. And they will not give you a chance to talk. The reason they do that is because hearing is so difficult, listening is so difficult, that they prefer to take over the conversation. And this way, there is no communication that is taking place. And that's the reason all of what Erber's techniques are that I talked about are great techniques where you can have turn taking. And then remember, I already talked about using appropriate communication strategies, appropriate reinforcement. And I've had these adults who come and say, I don't do anything that is against the person, but she'll be sitting with this angry look over there, or every 2 minutes that person would do this. I said, that is such a horrible sound you're making over there. And they themselves are not aware that they're giving this negative sound. It is a total non-speech kind of negative reinforcement that the person is giving. It just puts down the person. So always try and modify and encourage the communication partner to reinforce the person, encourage them. And then they should be able to modify their speaking style, talk in a way that it is more audible and understandable about there, and be willing to attend therapy with the client who's on, if they're undergoing therapy. So you should also address comorbid conditions if the person has it. And a lot of our patients also have a mild, they could be having also an auditory processing problem, especially once they cross over a particular age. There is a possibility that they have auditory processing problems. It's very difficult to run auditory processing tests to confirm this, but when you find a person doing extremely difficult and not making progress in your therapy, this is something that you should try and see. Can I try and run some kind of an auditory processing test that is not too affected by the peripheral hearing loss, and check out about that. And you could actually, some of them are the temporal based tests you could be running over there. And we've one of my doctoral students we have worked on, where we've actually taken people with mild high frequency hearing loss and people with normal hearing through and through, and these are older adults, and there's a significant difference between the two. And these older adults with mild hearing loss actually didn't even require a device, but yet there was a marked difference. So the peripheral hearing loss did have a problem. And a lot of our adults also have visual problems. So remember, address auditory processing problems, address visual problems, doesn't matter what it is, address all these issues. Telephone conversation is something that is really difficult for individuals with hearing impairment, because the frequency response of the telephone is really not good. And now with this current scenario, we're not only talking about telephone conversations, we're also going to be talking about webinars and listening through these different platforms that we are using right now. So they have to make sure that the device that they're using has got good frequency response. I keep talking about, recently we had a girl singing the invocation song in one of the functions that I attended recently. A lot of us might have attended also. And every time she went into a higher pitch, it just cut off. She had a transducer that was so terrible that it cut off the high frequencies and only transmitted the lower frequency mid frequencies. So you don't want to be using a device to transmit that is for transmission as well as for reception, which is poor. So make sure both the speakers, the person who's talking and the person who's receiving the content have devices that have got good frequency response, good connectivity, and if possible, the person with the hearing impairment should be using something with a direct input. And you see a lot of us would be wearing on earbuds into our ears so that we can hear clearly. So speakerphones, if you want, if it is clear enough. I'm going to be skipping this portion because a lot of this I talked about earlier, how you start with familiar topics and then go on with using communication strategies and you're shifting topics. But what I would suggest is you do it face-to-face with the person and then move the conversation to with the telephone. So I'm just going to go due to shortage of time. I'm going to quickly go through the rest of it, which is not typically something that you would do with adults, but if you want, you could be doing it with adults. So here, Urba's approach, and this is something typically you would do with children, but there's nothing to prevent you from doing it with adults. So you can categorize your speech sounds into different frequency levels, and then this is my own way of categorizing them. And then you have frequency discrimination for frequency. You could be doing identification. You could be starting with auditory and starting with simple tasks, and all of this. I said there's nothing to prevent you also trying to give them visual and tactile. The point is you want communication to take place. So if the person finds it very difficult, like Dr. Ratna just mentioned earlier, if you find all of these techniques not working at all, there's nothing wrong with moving towards using gestures or using sign language. There's absolutely, it is not wrong. It's a good thing to be trying out over there. And there have been adults there who lost the hearing and then they were doing so. This is before cochlear implants came, and I've actually recommended saying, why don't you use maybe some kind of cues, use signs or gestures along with it. So you always start off with the level, and when you're doing any kind of auditory training, you start off with running a test and find out, okay, what are the difficulties the person, and then you gradually move on. Train them with speech sounds that occur more frequently. And this is something that anybody who's gone through training with me would have heard me talk about Garsticky's approach over there. Again, more with the auditory training kind of activities. And you progress from each of them, from easy to more difficult, every one of them, easy to more difficult. And it's so beautifully given, saying how you can mix and match all these different content over that I put up on the slide. And you can be using this. You could be doing all of this also when you're doing your any of the earlier techniques that I have talked about. So the challenges that I talked about in the beginning, I'm going to wind off talking about it, saying, again, I say that people are not motivated. They don't have the required support. The major problem is mobility, and they're reluctant to undergo training. But with the current ongoing kind of technique that we have, I think this is a great opportunity for us to widen the kind of clients that we have in our clinics. I told you majorly they are reluctant to come over here because commuting is the biggest difficulty. So when I say online, I'm not saying you give the training directly to the client. It would be the communication partner. So you are motivating the communication partner through the communication partner, you're going to be doing all of this training, and it does work. And I just want to wind off with telling you about two things. Madhuri also talked about a study done by her, which she presented with about 2 individuals, where she talked about saying speech tracking definitely worked. And these were individuals using cochlear implants. And I'm talking about a girl who was about 16 years of age. She using hearing aid and she was doing so poorly. She actually came from a broken family. When she came to me, she came with a grandmother. And I was actually making a decision saying, shall I move her into a cochlear implant? So they came from a family that could afford cochlear implants, and I was talking a lot about it. So she's a 16-year-old. And I said, but before she went in, we tweaked the settings of the hearing aid. And then I gave her this set of communication strategies. And I said, and speech tracking, both the set, I gave it as written material, and I demonstrated to her just about not more than about 15 minutes in my session. And then this was in my office, I said, did it. And then I told her, go back home and you try it out. And the grandmother was there, and I was hoping that the grandmother would do this entire activity with her. And she came back, this girl came back to me about 3 months later on with the father, and they had come already to go in for the cochlear implant, because at that point of time, I did tell them that that was an option. And she was communicating so much easier. So I said, oh, your grandmother's done a great job and done training with you at home. And she said, no, it was my friend in school that helped me out. So the communication partner doesn't always have to be a family member. So it was a friend in school who helped her out. And here was a decision being made by me saying, instead of a cochlear implant, I told her continue with the hearing aid. So the point I'm trying to tell you is, don't make a decision right away about a cochlear implant, even for adults. Give them an opportunity through some training technique, let them go through some form of training, then make your decision about it. So you have effective rehabilitation. For effective rehabilitation, the cooperation of the family, the significant others such as employers, employees, and others in the community are absolutely necessary. So thank you again, everyone, for giving me this great opportunity to be talking in this landmark webinar series.
Thank you, ma'am. It was an extremely resourceful presentation. We had a lot of information put forth. You took us through various methods and techniques that can be used for communication training in adults with hearing impairment. And the clinical experiences shared were very impressive, very well understood. I think what we could do is we'll definitely be using these techniques and methods in our therapy sessions as well.
Thank you.
Thank you, ma'am. We have a few questions posted from the participant side, ma'am. Could we take them up with your permission, ma'am?
Sure.
Yeah, ma'am. The first question is, how can we modify the communication therapy when there is auditory processing disorder with peripheral hearing loss?
Okay. The first thing that you would, the person has a right to know about that, that they have a problem, and it gives them a reason to know why they have so much more difficulty. So I would give them probably some training. I'll give you this example of what we did with this technique, set of people who had peripheral hearing loss along with auditory processing, auditory processing problems. We actually, the training was more with reference to the auditory processing technique, and that's a different set of topics altogether. It's a 6-month course that we actually run. But very simply, depending on the process that is affected, that process, you give specific training. It could be verbal based, it could be non-verbal based, but what we gave here was non-verbal based set of training. The person, the individuals that we took in over there actually had temporal resolution problems. So the training was all about temporal resolution. And so there was definitely a marked improvement in these individuals. So it was not something that we noticed only in terms of behavioral tests, also in electrophysiological tests. We did LLRs. And this recently, there was another webinar that was talked about by Anu Sharma. And she also talked about just putting on a good enough device, a hearing aid for the person. And she talked about saying how these LLRs, the P1 came up over there. She talked about the latency of these waves. So just by giving training or just letting them listen properly with the hearing aid itself, that sometimes is enough. But I, as a person, would also recommend that you give some training for the person there, which could be more with reference to the processing difficulty.
Thank you, ma'am. The next question we have is, how can sign language be used for deaf people with moderate intellectual disabilities?
Okay. We don't call them deaf people. First, I would request that you can always refer to them as a person with deafness. with moderate intellectual disabilities. Now, if you talk about a person with moderate intellectual disability, they are going to be finding all of communication really difficult. And instead of my answering this question yesterday, Dr. R. Panjula should have been the person who should have been answering this. I would recommend using an AAC technique along with this. And you would always use some technique which is easier for the person to communicate with. I haven't really used sign language directly myself with a person with intellectual disability over there, so I'm not an expert with that. But I have used it with a child who's had autism. The child was actually using a cochlear implant and was making such poor progress through the auditory modality. I knew he was hearing and he was getting input, but because of his autism, he was not making the progress that was required of him. So it was a combination of AAC along with training for listening training, and the language developed through AAC. So he comprehended everything through AAC, and then gradually we made this transition. Now, let's take the same scenario for a person with the sign language over there. You would probably start off with sign language, and like Dr. Ratna talked about it, use that as a stepping stone to move in towards the auditory mode also. So you would use a bilingual kind of a form of training over there. And actually, I just wanted to add on over here when Dr. Ratna made that comment over there. Actually, in certain languages which are tonal based, like Mandarin, Cantonese, they are, even with the best of devices, those tonality changes are very difficult for the person to understand. And it is actually recommended that they always learn a bilingual form. So the tonal changes, they use a form of sign along with it, and the person hears the rest of it. So if you talk to the person in English, they have no issues at all. But the minute you move into Cantonese or Mandarin, the person, even though they have good hearing for English, they would find it extremely difficult to understand Mandarin or Cantonese. So it was actually recommended that for those languages especially, make use of signs. So there's nothing wrong about using any mode of communication as long as you can communicate. And I haven't directly answered this whole thing about moderate intellectual disability, because I think it would just be a longer time of trying to train the person, and it doesn't matter that you're going to take much longer than what is required over there.
Yeah, thank you, ma'am. Those were the two questions that we.
Yeah, thank you. Thank you for participating and presenting a very informative lecture we had. Thank you so much.
Thank you, sir. The pleasure was mine.
Janab.
Yes, sir. Ma'am, on behalf of JSS ISH, I request you to kindly accept the letter of appreciation for being the resource person in today's webinar, ma'am.
Thank you so much.
Thank you, ma'am. Madhuri, ma'am, are you here, ma'am? I hope you are feeling better.
Yeah, I'm fine.
Ma'am, we will definitely mail you the questions which you can answer them. And I really thank you from our side. We thank you on behalf of JSS ISH for being the resource person for today's webinar. I request you to kindly accept this letter of appreciation on our behalf, ma'am.
Yeah, thank you.
Thank you so much, ma'am. This is the kind note for the participants regarding tomorrow's sessions. We have 4 sessions scheduled for tomorrow, 2 in the morning and 2 in the evening. So I request you all to kindly make it convenient to attend the scheduled sessions at the respective timings. I will post the feedback link in the chat box. Kindly leave your feedback for today's sessions.
Thank you. We can close.
Thank you, sir. Thank you,
Thank you
Madhuri. That
very
was
much. Thank you.
Thank you.
Sorry,
Thank you all.
not feeling too good.
Yeah,
Thank you.
just yeah.
Sir, we'll be there. We'll close it after 2 minutes, sir. People who have to fill the feedback, let them fill it.
Okay, okay.
Yes.